Hello, I'm Daniel Stackowicz. I'm going to be presenting on immediate confidence, practical techniques for single implant immediate placement. This lecture is going to be about placing custom socket sealing abutments on the Tuff Unicon Tuff implant and prosthetic line, and how to preserve the shape of the tooth so we can make our best fitting, best looking, longest lasting implant crowns. So a little bit about me. This is a little bit about my background. I went to undergrad at Valparaiso University in Valparaiso, Indiana. Graduated in 2010. I got my dental degree from Indiana University School of Dentistry in 2014. Then went to oral surgery residency and medical school in beautiful Houston, Texas. Graduated medical school with my MD in 2018. Oral surgery residency 2014 to 2018, and then my general surgery intern year 2018 to 2019. I returned to general dentistry in 2019, limiting my practice to station, implants, remote anchorage, fixed full arch dentistry, and oral surgery. Currently, I practice in Meridian, Idaho at Dental Implant Solutions of Idaho. Our practice here is limited to fixed full arch solutions, implantology, remote anchorage, full mouth rehab, and reconstruction. This is how beautiful Boise, Idaho is. People think Idaho, potatoes. It's not that. We have tons of mountains. We have tons of snow, usually, not this year. And if you look at that mountain right there, if we zoom in, that is our local ski resort. It's like 45 minutes from Boise. And it's a beautiful ski resort, lots of runs. Idaho has some of the best ski resorts in all of the Northwest. I think we have like 10 or 15 chairlifts at Bogus. And those are the views at Bogus when you go night skiing. So this is why I love Idaho. Come visit and come see some implants place here, and we'll go skiing afterwards. Okay, the overview for this webinar is going to be mostly a step-by-step surgical and restorative workflow. We are going to be going through a few cases and discussing the individual uniqueness of each case. We're going to be talking about the EBC zones and how we're going to design our immediate provisionals using those zones, and what we need to do for our immediate implants as far as like how deep we need to place them, how far away from the buccal keratinized tissue margin, and then how to manage the soft tissue around those single implants to keep that buccal corridor full to prevent collapse and loss of buccal tissue support. So the key questions that I want you to be keeping in mind are: how deep should the implant be placed? How far from the buccal gingiva? Where and when and with what to graft the gap? And how can I best preserve the gingival emergence profile of the natural tooth? So the Tuff Unicon, the conical connection is key. If you are using an internal hex, an external hex, if you're not using a conical connection, you cannot place the implant subcrestal, and you will not be able to get the idealized emergence profile for the EBC concepts and how to preserve our soft tissue and allow the best crowns to fit onto our implants. So is there any situation where an immediate implant or immediate custom socket sealing abutment should not be performed? Some people will say, no, you can place an immediate implant in every single situation. And while I don't necessarily disagree, there are some times when I consider not placing an immediate or not placing immediate custom socket sealing abutment. These are all able to be overcome. An implant can be placed, but I like to think that maybe the difficulty of the case, the predictability of the case, or the patient acceptance and the risk is too much for me or too much for the patient. And in those scenarios, I would consider not placing an immediate implant or not placing a custom socket sealing abutment. And those 2 to 3 situations are the inability to achieve primary stability. There are certain implant brands, certain implant types that technically you could place a 0 Newton centimeter immediate implant, cover it with bone, and the blood clot will form and create all new bone, and that implant will become integrated. These are more niche, unique scenarios. Another situation is unable to fully degranulate or disinfect the extraction socket. We all know sometimes those granulation pockets, that infection has these weird tunnels, and you can chase that all day, and sometimes you feel like you just aren't getting good enough disinfection around it or clearing all the granulation tissue, or if the granulation tissue is right up against the inferior alveolar nerve or right up against another tooth, sometimes the risk of taking that out and involving the inferior alveolar nerve or involving a nerve or blood supply to an adjacent tooth is too risky. And we don't want to place an immediate implant or a custom socket sealing abutment on an immediate implant if we are not completely disinfecting the extraction socket. So that case, I would also not place an immediate implant. Or if there's really poor gingival tissue, if there's a lot of fenestrations, if there's multiple fistulas exiting out the buccal, or if there's adjacent teeth that have, periodontal disease, subgingival calculus that need to be cleaned, and we're not going to be doing it at the same time, then I would probably have them take the tooth out, take the infected tooth out, have their periodontal disease, their subgingival calculus removed, get everything to a better standard of healing, a better healed tissue, and then go back later and place an implant as a delayed implant. Okay, so the first case that we have here is an emergency patient, tooth number 5. There was no way I could pre-plan anything. This patient came in, it was in the afternoon, and said, "Hey doc, can you fix this broken tooth?" The tooth broke that day when the patient was eating lunch. Obviously, there was other issues with the tooth before the patient came in, but this is what presented. So what can we do in this case? We can extract the tooth, preserve that nice buccal tissue, preserve the emergence profile of the existing tooth with a custom socket sealing abutment with a custom shaped crown. Now, as long as that crown is not in occlusion or involved with any interferences with chewing, we can restore the smile so the patient doesn't have to have an Essex retainer, doesn't have to have a temporary partial denture that comes in and out, but then that crown is attached to the tooth, and see the implant placed. And now the tooth is out. We atraumatically extracted that tooth to preserve as much of the buccal and lingual contours as possible. You can see that the implant depth is appropriate. We want to be about 4 to 6 millimeters from the free gingival margin of the keratinized tissue. And then we want to be always more lingual. This is the x-ray where we have the temporary in place. We can see that the x-ray here, it looks like it has this weird step to it, but that's actually the buccal projection. And since it's slightly tilted, it looks like we have this weird step, but that is the buccal portion that's extending horizontally from the lingualized implant buccally to give us that needed buccal gingival support. And you can see the depth of the implant on that middle x-ray that sliced the CBCT. We are very lingual. We're pretty deep in the bone compared to the adjacent teeth, but that way we are going to be able to have a nice, beautiful curvature of our emergence profile. And then the panel view, the last x-ray here, you can see that we are about midway through the adjacent teeth, so we can have as much room as possible for zirconia for healthy tissue attachment. For placing these implants, we can see that the depth and the distance from the buccal tissue is key in following an EBC protocol and having ideal emergence, depth and distance from the buccal. So if our gum tissue is in this location on that x-ray, then we want to make sure that we are deep enough at the apex and from the crestal bone so that we can have enough of our tissue and zirconia, or in this case, composite for our temporary, to be built up in a way to give us this idealized curvature. So this pink line here is the distal curvature. And again, that little fin that's there, that's actually the projection of the temporary going buccally to support our buccal soft tissue. We want to have about 2 millimeters, 1.5 to 2 millimeters of buccal soft tissue support. And then everything else above that can be filled with graft material, bone, PRF, or just letting the blood clot form and fill it with bone as it heals. So here's our 3 zones. Our zone that is closest to the platform, we want to have at least 1 millimeter of straight tissue to allow for hemidesmosome attachments and for good tissue support. Our next zone, we want to have a slight concave profile, and then our last zone is going to be a convex profile to support all the buccal soft tissue. So our C, B, and E zones, which correlate to our crestal zone, our bounded zone, and our aesthetic zone. Okay, so this is the same patient. So now we have our temporary built custom socket sealing abutment, giving us the projection of the crown. Now I knew since this patient was an emergency patient, I didn't have any time to digitally prepare. On the pictures on the right side of the screen, I could have closed those gaps a little bit more, but we scanned this implant before we put the custom socket sealing abutment and crown on it. So we could then digitally make this 3D print it and put a better one on in the next couple of days here. So this is our initial temps, 25 days post-op. Patient came back, and the healing around our temps, even though that the contacts are not perfect, the contacts don't have the best shape, we can see when the temps come off, regardless of that, we have a great papilla still between the two teeth, and we have preserved almost exactly the buccal keratinized tissue where the original tooth was. So then the 3D design and printed provisional now on a stock definitive tie base is placed. We get blanching of the gingiva as we place it to make sure that we're getting pressure on the tissue and completely closing the margins, completely closing the contacts. And this is how the patient looks at 25 days post-op. We could have done this earlier. We could have done this at 1 day post-op, 2 day post-op, 3 day post-op. For this patient, it just happened to be 25 days post-op when we delivered the 3D printed provisional on a stock tie base. So this is a comparison of day 0 of surgery with the tooth extracted. You can see the buccal tissue contours, and then at day 25 from the scan done on the day of surgery, almost identical shape of the gingiva, but now we have that full tooth filled in, looking much better, more aesthetically pleasing, but it's going to keep that tissue preserved exactly how we want it. Okay, so this is case 2. This is very similar. This is extraction of tooth number 5 with an immediate socket sealing abutment. On the leftmost side of the screen is going to be the initial presentation where we have this crown that is fractured completely off. We placed a Tuff Unicon Tuff implant immediately, and we placed that implant more lingual and deeper than a crestal implant would be placed. We built a custom socket sealing abutment with a crown that is not involved with occlusion or any interferences with chewing on a stock temporary chimney. The x-ray shows the stock chimney in place, making sure that we're not compressing a bone and that we're fully seated. And then the custom socket sealing abutment crown completely built, showing our contours and our emergence profile. Now, because of this location, because of the size of that crown, it is expected when they come back at 3 weeks, 2 weeks, 1 month post-op, we're going to see some loss of that interpapillary bone, that interdental bone, as it goes through remodeling, just so we can recreate how much soft tissue we want for that bounded zone, that crestal zone, and the aesthetic zone. So then 1 month post-op, we take the crown off and we can see how good the gingiva has healed, how it is completely preserved the shape of the buccal tissue. We haven't lost any keratinized tissue on the buccal, which is going to allow for a much longer lifespan of that implant crown. So again, we have our initial presentation, we have 1 month post-op, now we have our 3D printed temp that we delivered at 1 month post-op based on the surgery scans that we took the day that we placed that implant. The x-ray shows us the day of surgery, and then 1 month post-op. You can see that the bone interdentally and at the crest is going through some remodeling as it establishes its soft tissue contours. But if we put a zirconia crown on this at that time, we would see all that bone come back and reform. Okay, third case here, we have a number 29 extraction, immediate implant, socket sealing abutment, and then we're going to go all the way through the final crown. So you can see the initial presentation of tooth number 29. It has pretty large distal decay. This is post-extraction. Now, we did not preserve the gingiva as much as possible. This was not an atraumatic extraction. Some of the gingiva was torn. We had to be a little bit more aggressive taking the tooth out, which happens no matter how gentle you are, no matter how atraumatic you try and take a tooth out. Sometimes you have to open it up. Sometimes you have to flap it to get the tooth out. Now, even with that, we still can get a really great result for a immediate implant, preserving the shape and contour of that gingival socket. So again, that implant is placed lingual. It is placed deep, 4 to 6 millimeters from that free gingival margin. The deepest point, or the most apical position of that free gingival margin, we want to be measuring 4 to 6 millimeters to the platform to allow for that zirconia or that composite to create the right shape of our custom socket sealing abutment. So this is 3 month post-op where we're going to scan for our final crowns. Even though we do scans at the day of surgery, if I'm able to, I'm always going to take another scan at around 2 to 3 months so we can make sure that any changes that happen. Now, in this case, we're definitely going to take a scan before going to finals just because of how much we had to reflect that flap on the day of surgery. So now we can capture the exact profile and shape. So you can see how much vasculature is underneath that temporary crown. Again, how lingualized that implant platform is, but how well preserved that shape of that tooth number 29 is. And then from the buccal corridor view, we have all that preserved keratinized tissue on the side. This is at 5 months post-op at the time of final crown delivery. Again, take everything off, documenting all of our pictures. You can really see how beautiful all that tissue has healed. And then with that tooth number 29 final crown placed. If you look at it from occlusal, we do have some loss of that buccal tissue width. So in a case like this, it would be totally acceptable and reasonable to do a free gingival keratinized tissue graft, partial thickness, and kind of tuck it in underneath the base of each papilla through a little tunnel and bulk that tissue out. Now, of course, the cheek is kind of compressing it, so you're not able to see the full contour. But from a straight buccal shot there, you can see that we still have enough keratinized tissue. It's really hard to actually see which tooth is the implant crown, right? It doesn't look like a standard implant crown that's sitting on a peg and that has really steep margins. Like this looks like a very natural tooth because we replicated it from the day of surgery. So this is just comparison when she first presented. There's tooth number 29. And then at delivery, like very, very similar shape of the tissue. We preserved all the anatomy, preserved exactly how it should be. So the body really didn't know that it underwent very much change, was able to preserve as much as possible. This is going to provide excellent cleaning, excellent gingival stability for years to come. Okay, tooth number 7. Now this is a delayed case. So the patient had already seen another dentist, had tooth number 7 taken out a while ago. You can already see that we're immediately met with so many challenges. We have a ton of loss of that canine eminence or the facial soft tissue in the facial buccal plate. So we're going to need to bulk that up. We also have quite a bit of gingival recession on the distal of number 8, which we can try and do at the time of surgery. So immediate implant, flapped everything. We can really see how much bone that we've lost on the facial. Placing the implant slightly more lingual so that we have our access hole coming out through the cingulum. Bone graft, membrane, and suture everything closed. Again, in retrospect, the papilla on the mesial could have been sutured a little bit better with a periodontal sling suture to try and bring that papilla up and over and get that to regrow from day one. I already had planned on going into a second surgery with this patient, but I think we could have preserved that initially from day one better. So presentation, and then with the immediate custom socket sealing abutment, since this patient was delayed, we had time to have this 3D printed and prepared beforehand. So I was able to place the temp cylinder over a hollowed out provisional with wings on number 8 and number 6 to place that exactly, fill it with resin, and pick it up in that exact location, giving us the right facial planes. So here is the 3D printed temporary on a definitive socket seal or definitive tie base for our socket sealing abutment. And we can see the shapes of all those EBC zones and exactly how we're going to preserve what we would want the tissue to look like. Now in this, we're not preserving the position of the tooth that was extracted. We are basically recreating it from nothing. So now we can idealize the emergence profile, and the only way to do that is placing the crown deep enough and lingual enough, and the only way we can do that is if we have a conical connection. So unfortunately with this patient, she came back, she probably wasn't following post-op instructions. Even though this was out of occlusion, it fractured. Okay, so fractured off the temporary cylinder, and we can also see that we have some swelling and some loss of the buccal suturing, bringing the tissue where we wanted it. So this further complicated the case, but we can still see that this is going to be better than placing an implant, suturing it back together, letting it heal, and then coming back and trying to recreate this after the implant is placed and healed. So we were able to then place a new 3D printed temporary on a stock OEM tie base and put it back in place. Color could have been better, but again, this was like not planned to be done that day, so we had to print it quickly and didn't have time to colorize it. We did end up switching it out later, but you can see how this now has healed, and we have a much better gingival contour. We have thicker gingival tissue. Still isn't as as filled in as I would like, even though we have quite a bit of fill in the initial 2 to 3 millimeters of that keratinized gingiva. We just need more projection buccally. This patient luckily doesn't have a high smile line, so it's not extremely noticeable, but we're still going to fix it. In this bottom picture, you can really see how utilizing the shape of that custom temporary, that socket sealing abutment provisionalized crown, we are creating the tissue pocket that's going to create a perfect seal. And actually, when I took this crown out, we did have bleeding of that hemidesmosomal attachment in the bound zone. All right, so this is the second surgery, custom, we're doing a soft tissue graft to fill up that buccal, and then suturing everything a little bit better. We did have a little bit of tear, which had to be sutured. This patient is still in temporary, so stay tuned for an update on that case. Case number 5, number 20, socket sealing abutment. So this patient was a combined case doing a full mouth veneer restorations on the top jaw and lower jaw. Same thing, veneers on all the teeth, but he had 2 primary teeth that we were going to be recreating with custom socket sealing abutments. So we have intraoral scans showing us tooth number 5 with our custom socket sealing abutment from the occlusal and buccal view, preserving all that buccal shape. Tooth is out, implant goes in. You can see again it's slightly lingual. It's deep, 4 to 6 millimeters from the free gingival margin at the deepest area. And then the PA X-ray showing the temporary cylinder place, make sure that we're not having any bone interfering with that. And then with our custom socket sealing abutment to preserve the shape of that tooth. And then on the bottom left, we can see more of that crown, preserving it 2 millimeters below that free gingival margin to bulk up that tissue, prevent collapse and shrinkage. And then you can see the shape of that tooth, highly polished, and with that little buccal, that buccal extension to preserve our tissue there. And this is at day 5. You can already see that the gingiva has healed pretty well around it. Atraumatic tooth extraction, we're not really messing with the gingiva. And it doesn't have anywhere to go, it doesn't need to shrink, it doesn't need to heal because our temporary is preserving it and sealing it and preventing any shrinkage from happening. Case number 6, we have a delayed implant with immediate socket sealing abutment. So you can see this patient had the tooth extracted. We're lucky that they have a very thick gingival biotype, and we're going to be placing the implant, flapping the tissue, doing a modified buccal roll to buccalize as much of that keratinized tissue, because you can see because of the delay, even though we have a really thick gingival biotype, we've already lost some of that buccal keratinized tissue. So we need to steal it from the lingual and replace it with our custom socket sealing abutment. Okay, so here is our flap. We have our lingualized incision zone. Our implant is placed to depth. Since we don't have the free gingival margin to measure from, we know that there's going to be about 2 millimeters of gingival tissue there. So we need to place it at least 2 to 4 millimeters deeper than that position. With the design of the Norris Unicon Tuff implants, they have a really aggressive thread shape. It allows you to have a short implant like this and get really high torque values, have really good primary stability, and still be able to place it deep enough without having to do something like a tissue level implant to give us the buccal and lingual contours that we need. So once I created that custom socket sealing abutment on that temporary cylinder, just suturing the buccalized flap to the buccal and to the lingual, slightly over, because I know I'm going to have shrinkage. I know that by doing this in this delayed site, I'm going to have some of that tissue shrink. So I'm kind of increasing the amount of tissue above it, allowing for shrinkage to happen. And this is at 3 weeks post-op. The shrinkage has happened, but it's shrinked almost exactly to where we would want it to go, allowing for pretty well-preserved shapes, as if the tooth had been extracted and the implant been placed at the same time. So again, comparison day of surgery and 3 weeks post-op. And then this is at 6 months post-op with the final crown. So if we take the temporary socket sealing abutment off, we can really see how well healed that is, how good our buccal contouring is using that modified buccal flap, suturing it higher, allowing that shrinkage to happen. If we had sutured it at the level of our temporary socket sealing abutment, we would have lost more height, and because we would have been losing more height, we wouldn't have had the buccal support from our custom socket sealing abutment, which would have allowed shrinkage underneath it. So preserving that buccal contour, and then the crown in place looks like a natural tooth, is preserving that exact emergence profile that a tooth would have. And with the highly polished zirconia subgingival portion that isn't glazed, we can almost guarantee that there's going to be no probing depths around this final implant. The patient doesn't have to use a water pick. I tell them that when they floss that they just floss between the contacts, but they don't try and get the floss underneath that crown like a crestal implant or like a natural tooth, because every time they do that, it's just going to cause bleeding and then eventual tissue loss. Because with that highly polished extracept polishing of zirconia, we know that we're going to have blood vessels ingrowing and attaching to that zirconia. That extra step of zirconia polishing done right by the lab is just going to be taking it up to the yellow polishing disc. And then the last step is doing a diamond polishing paste. No glaze underneath the gingival tissue. That diamond polishing paste is going to give us enough of that high zirconia finish to allow vessels and capillaries to grow into it and attach. All right, so here is our progression. Pre-op, immediate tooth is out, site is healed. Day 0, accounting for soft tissue shrinkage. 6-month post-op with the final crown, completely recreating that buccal tissue, keratinized tissue, and emergence profile. And you can see at the 6-month post-op compared to day 0, we have almost zero loss of buccal bone height. We have a little bit of bone that has kind of receded from our temporary that's placed, but that is to allow for soft tissue to form in our EBC zones. All right, case 7. So we're doing 3 implants here, 3, 14, and 30, delayed implants with immediate socket sealing abutment. Patient had these teeth lost, and we're going to go back in and replace them. Okay, so we have the lower right site, tooth number 30, again, modified buccal flap, immediate goes in, custom socket sealing abutment, and then suturing that buccal keratinized tissue slightly higher, knowing that it's going to shrink. And then these are the 2 on the upper, number 3 and number 14, very similar. Recreating the shape. We didn't have a tooth to copy, so we are just basically creating this out of nothing, making sure implants are deep enough, suturing our buccal tissue slightly higher, knowing that it's going to shrink during healing to give us that buccal thickness and that buccal emergence profile that we want. This is at 6-month post-op when we're going to be scanning for our final crowns. Whenever we do these delayed, we're always going to have more sets of scans than just doing an immediate. If it was an immediate, I feel confident scanning the day of surgery and then sending that day of surgery scan for finals. Since this is delayed, we don't know exactly how the buccal and lingual tissue is going to heal. So we're going to scan at the day of surgery just in case we need to go to a interim lab-made or 3D printed provisionalized temporary. But I still want to do a final scan to recapture how all the gingival tissue has healed. So we have our 6 months healed, taking the temporary socket sealing abutments off. You can see how good that tissue has healed around them, make sure everything is well sealed. Here's zoomed in on how that tissue looks when it's healed. We just have great tissue adaptation, great buccal contours, almost looks like the shape of the crown, even though we had no crown to replicate. And then the final crowns on the picture all the way over here. Again, with the trained eye, we can see exactly which teeth are being replaced. But to the patient, to anyone else that's seeing the patient smile, it's really difficult to determine which tooth is an implant. We know this 3, 14, 30 because it's listed on the slide, but we can't really tell. We don't have that classic, long crown or that classic shrunk-in appearance of the buccal contours. These look like natural teeth, and that's what we want to do because we know natural teeth are going to function like natural teeth. If we can replicate our implant crowns look like that, it's going to function, last longer, and just be better overall for the patient. Okay, so primary stability fundamentals. To immediately load, so I'm not talking about a custom socket sealing abutment that's at the level of gingiva, but at least that it has part of a crown. Even if that crown is taken out of occlusion, I want at least 15 Newton centimeters to be out of occlusion. If I'm going to allow the patient to chew on it, then at least 30 Newton centimeters. And as long as it isn't like excessive forces, as long as they're not having extreme excursive movements interfering with that, I feel confident if I'm at 45 Newton centimeters to have that crown be in function from day 1. So here's our surgical workflow. Extraction with immediate implant. We're going to atraumatically extract the tooth. We're going to preserve the gingival contours by not making an incision, by not being too aggressive with our extraction. We're going to degranulate, disinfect, and sterilize the socket. We can degranulate and disinfect with our rotary instrumentation, our curettes, and we can sterilize the socket with iodine or consider doing what we call yellow sticky bone, which is just our regular PRF sticky bone, but adding a couple of drops of iodine with it. So as the body resorbs that sticky bone, it's going to release the iodine, prevent any bacterial ingrowth or any remaining bacteria that might be left in the socket from growing into that bone graft, growing into that sticky bone and causing complications later. We're going to place our osteotomy, and then we're going to place our implant. Okay, this is pretty standard osteotomy implant placement. We just need to make sure that we are 4 to 6 millimeters from the keratinized tissue, and then lingual as much as possible. Again, at least 4 to 6 millimeters from the buccal tissue. Before building up our socket sealing abutment, I always recommend taking a PA X-ray to confirm that our temporary abutment, our temp cylinder, our chimney is fully seated. What you don't want to happen is a piece of bone graft be interfering with that full seating. You build up your whole custom socket sealing abutment, you take it off, you polish it, and then you go to put it back on, and now it seats completely different because it wasn't fully seated initially. When we build and shape the socket sealing abutment on the temp cylinder within the extraction socket, we just need to be careful that we're not just taking our octopus tentacles or our little like arms and just putting them on top of the gingiva. We need to make sure that we're supporting it 2 millimeters, 1.5 to 2 millimeters below that, so we don't get that shrinkage of that buccal and lingual tissue. And what I do is while I'm shaping that temp abutment, when it's out of the mouth and while I'm shaping it and filling in any voids, I have my dental assistants place the scan body, take a PA X-ray to confirm that the scan body is fully seated, and then take the intraoral scan at that time. Efficient workflows is key. This is going to make it so the patient isn't sitting in your chair an hour after the implant's placed while you build up your custom socket sealing abutment and then take your scans and then take your X-rays. Efficiency is key here. Once you're done shaping to the EBC shapes, your temporary custom socket sealing abutment, you are going to then put your graft in, whether it's PRF or you do PRF poncho or bone graft. You're going to place your graft in such a way that you can compress all the tissue, but it's not going to prevent you from seating it all the way. You're going to then place it, you're going to torque it down to 15 Newton centimeters. Ensure you have a proper gingival seal. So if you take your perioprobe and you probe around it, you're going to make sure that everything is fully sealed. If it's not fully sealed, you're going to have shrinkage, you're going to have a loss of buccal contour, you're going to have bacteria infiltration into that area. You no longer have a socket sealing abutment. You have an open socket. And you're going to lose bone, you're going to lose bone graft, you're going to have issues to deal with later. So at that point, if I don't have a perfect seal, I'm going to add composite, take it off, repolish it, reshape it. The goal is to only take it off once and put it back, but sometimes things change, you overpolish it, you need to refine it. For delayed implant placement, I prefer to have a prefabricated 3D printed temporary with wings on the 2 adjacent teeth and a big hole in the middle, so then I can ensure that when the temporary cylinder is in place, I can pick up the teeth on that temporary abutment exactly how it should be to preserve all those buccal and gingival contours. If you don't have that ability, or a patient comes in and you have time in your schedule to do it right away, you just make sure that you just shape your custom socket sealing abutment with composite to be the idealized tooth shape and size. For these, sometimes I'll just do it completely on the back table, not in the mouth. Put it in the mouth and then maybe add some more, take it back out and reshape it. Always consider on these delayed implant placements doing a buccal roll or a soft tissue grafting at the time of delayed implant placement. I could go through a whole 45 minutes, hour, 2 hour, 3 hour lecture about gingival grafting, soft tissue management, and how to account for shrinkage, but that is its own webinar in and of itself. So maybe we'll do another webinar later on exactly that subject, but not in this webinar today. So now we're going to build our custom socket sealing abutment. So it's important to lubricate below the platform with petroleum jelly. We don't want to have our composite going below the platform of the temporary cylinder, or else you're going to try and take it with a burr or a polishing wheel, and you're going to end up hitting your temporary cylinder, which is going to create a defect where either bacteria can grow or you're going to have tissue. And when you go to place your final crown is just not going to fit as perfectly because you're going to either have tissue or bone in that site where that defect was created. It is super important that you use high viscosity, heavy flow composite. If you just use your normal flowable composite, it's just going to sag and you're going to have a hard time chasing your octopus tentacles that are going to support your gingiva. So make sure that you have a high viscosity or heavy flow composite to do this. Before you put that temporary cylinder on the implant, I would recommend doing a 1 millimeter high and 1 millimeter wide ring of composite around the platform of the temporary cylinder. So that way you know that you don't have any bone preventing you from fully seating your temporary cylinder. When you do place your temporary cylinder, make sure you verify seating with the X-rayed. You're going to build your tentacles to support those gingival margins, and then you're going to extend that heavy flow viscosity composite at least 1 millimeter below the gingival margin to allow for the adequate tissue support and prevent gingival collapse and shrinkage. Anything that's below, so if you have lost your buccal cortical plate or you have a large amount of gingival tissue to support, I would not recommend bringing your temporary socket sealing abutment composite below that 1 millimeter. Just support it with a rigid grafting material like bone. And then be sure to account for any likely shrinkage of tissue, either by suturing that gingival tissue higher, allowing for shrinkage, or by doing a connected tissue graft at the time of your surgery. Once you have your tentacles built out around the gingival sulcus, you're going to then fill any gaps. You're going to cut the cylinder, remove it from the mouth, shape the intaglio of it, and then polish it to a high shine without any debris or microporosities. This is the most important thing. Make sure there's no debris there. Make sure there's no microporosities. Put it in a bag with isopropyl alcohol, shake it in the ultrasonic for 5 minutes when you're all done before putting it back in the mouth. So this is a diagram of basically what we're going to be doing, very simplified. So outside the mouth, before we place it, we're going to lubricate with Vaseline, petroleum jelly, below the platform. And I have this on a lab analog, so allow for better handling. We're then going to do about a 1 millimeter thick and 1 millimeter high composite ring above the platform. And the reason that the Vaseline was placed, the petroleum jelly was placed, was so that any composite that flows over can just be flicked off very easily. It's not going to bond to that part of the abutment below the platform. Now we're going to place the temporary cylinder onto the implant, take an X-ray to confirm that it's fully seated, and then build our octopus arms out to make sure we're at least 1 millimeter below the gingival margin for adequate tissue support. Then we're going to fill in the gaps with flowable composite. We're going to then take this out of the mouth, and we're going to fill any more gaps that need to be filled, and then shape it, and then place it back, confirm seating, refine it as needed. The bone graft, all the grafting would be done before this is placed back in. What I would want for my armamentarium for this procedure, of course, is going to have all the surgical setup, all the surgical supplies for taking out the tooth, depending on your preferred method. We're not going to go through how I do all my immediate implant surgeries. We're just going to talk about making the temporary socket sealing abutment. So I always want a pencil, and that's so I can mark that margin. So when I take it off, the temporary socket sealing abutment off the implant, I know how much not to polish. I know which level to polish to and not to take it above it, or else I'll lose that gingival support. For Norris implants, for the Unicon implants, we're going to have our 048 driver. We're going to have our temporary cylinder and our Unicon lab analog. We're also going to have whatever scan body you want of choice that fits on the Norris implants to scan it, or have your dental assistant scan it while you are modifying the intaglio, polishing, and getting everything else ready. So how do I do the polishing of everything outside of the mouth or in the mouth? How do I get this all contoured? You can get an intraoral composite or zirconia polishing kit, which has all these different things that you might use, might not use, or you can just build your own kit. 90% of my shaping is done with a diamond football. I have a carbide if I need it for little small areas around burr if I need to shape things specifically, and then I just have a white stone burr and a greenie to get me to my final polish. This is 90% of what I do. A lot of times, because I have a pretty nice lab setup, I will just take it to the lab and I can just use a lab handpiece and do all my really high polishing in the lab. So shaping and refinement of the EBC zones are usually done with those 3 burrs. Gross reduction is done with a coarse diamond burr to take any, if I build up too much composite, I can just cut it all off, cut the cylinder off with this. Initial polish with the white stone burr, and then my final polish with my greenie. Okay, so this is with an actual case here on the model, and this is gonna be very similar to what I'm showing. This case I want to show a little bit different because it's like a palatal root implant placement for immediate, because a lot of times with these immediates in the molars, if you're gonna place an immediate, not everybody has perfect interfurcal bone to place your implant in that position. A lot of times the sinus is gonna be invading that space. So it's more common, at least in my experience, to be placing these immediate molars in the palatal root, which makes a really funny looking temporary, which I'm gonna show here. So the implant is placed to depth 4 to 6 millimeters from that lowest point of that gingival margin, which you can see there, and then 4 to 6 millimeters. This one's much farther because it's in a molar from the buccal tissue. Okay, so here I have the lab analog with my temporary cylinder, holding it with the hemostat, placing my Vaseline around that collar, keeping it below the platform. We don't want any of that Vaseline to get into the collar. Vaseline is placed, pre-lubricated, and then I have that 1 millimeter tall, 1 millimeter wide amount of composite, and I'm placing this outside the mouth, and then I'm going to unscrew it, obviously cure it, unscrew it, place it on the implant, and take a PA X-ray to make sure I'm fully seated. And sometimes when you do this, you're like, oh man, I can already feel that it's not hitting, or it's not fully seating, it's hitting some of that buccal bones, hitting some of that interfurcal bone, so that's the perfect time. You take it out, shape the bone with your surgical handpiece, do whatever you need to do to make sure that fully sits. If you're compressing the bone, you just know that you're going to lose that bone anyway, so why not just let the body have a better chance and quicker time to heal by removing it for it, so then it does not have to do it. So this is the temporary cylinder placed with our composite ring, making sure everything is seating fully. We would take a PA X-ray at this point. And then we're going to start by doing our gingival octopus arms. I have seen a lot of people like to put Teflon. You can buy wide Teflon tape. You can put that under there to prevent bleeding. If the socket is really bleeding, you can do that. You can also just take your collagen tape and just pack it, knowing that you're going to take that collagen tape out and put a bone graft in later. You can use basically anything. You can put gauze, 2x2 down there to stop the bleeding. But Teflon tape also works great. You can also do it if the bleeding isn't major, just with it uncovered. You don't need to place Teflon. So again, you can see that these octopus arms are not going just to the top of the gingiva, which is the biggest mistake I see people make when they start doing this. It's just they just extend that composite right over the edge, but they're not supporting that gingival tissue. And then we're going to further place this. Now you can see how long these arms can be. And if you don't have a high viscosity flowable, you can see even with my high viscosity flowable, it already has this dip. It's already starting to sag. And if you don't have high viscosity flowable, that sag is just going to go all the way down, and you're going to have such a hard time building that to the free gingival margin. And you won't be able to support it. You won't get a good seal. You won't get compression. So you can see that's to about 1 millimeter, 1.5 millimeters of gingival support. At this point, now that we have all of our octopus tentacles extending to the gingival margin, I first like to go all the way around that buccal tissue in one ring, cure it, and then start filling each one of those triangles in individually and cure it. I feel like if you try filling in too much at once, the intaglio just becomes a mess and more voids possible. Doing it like in each section, in each triangle, gives you a little bit more control. Your intaglio is still going to look pretty awful when you take it off. It always does. You're going to have to fill it in. You're going to have to polish it. But I feel like this way you get the least amount of voids in between all the arms. And then I always overfill it. So at the point, that second to last picture where our composite's fully filled in, you can see it's a little bit below the 2 papillas, mesial and distally. So I like to build everything up so when I do polish it, I know I'm going to reduce it a little bit. And in that final fill, I'm going to extend a little bit over the gingiva, because that is going to, when I take it off, you're going to see this little flash. And then I'll mark that with a pencil, because that really will tell me exactly where the superior most portion of my composite needs to be for full tissue support. So here it comes off. You can see that flash all the way around. So I know that I can just mark that with a pencil and I can just polish that. I don't need to do any gross reduction and I'll still get a good seal. And then I'll take a pencil and I'll kind of mark where I've built my tissue supports. And in this case, you can see we have a ton to fill in. And that's totally normal. But we know that by filling it in, as long as we keep that 1 millimeter ring that we made outside of the mouth beforehand, if we just connect those two, we're not going to seed it and then be hitting new bony contacts. If we just connect it, polish it, shape it, we're going to be golden. So again, from the side, because this is a palatal root based implant, we're going to have quite the buccal extension, right? For these EBC design crowns, they look funny. They can look funny, especially if you do something like a palatal root, because they're so much more lingual than what we're classically trained, putting it like directly in the middle. As long as we're tilted and we still have that access hole going right through the central fossa, we're going to have a great long-lasting crown. So at this point, I'm going to put my, either myself or one of my dental assistants is going to put the scan body on. We're going to take an x-ray to verify that it's fully seated and then scan, so then we can go directly from this to a final crown if we need to. Say the patient, does lose some soft tissue, or I see some bone loss starting to happen. I can just go immediately to the final zirconia crown, and we can regain all that bone that's going through change. So this is, in this example, this is what the final shape of that custom socket sealing abutment looks like. It looks like Snoopy has this long buccal extension, but you can see we at least have that 1 to 2 millimeters of soft tissue support. All the way around, we have our EBC zones properly shaped and contoured, and you can see how that x-ray from that first case, how it kind of looked like it had that weird step, and that's because if the x-ray isn't perfectly on, you're going to see that buccal support extension look like it's this weird step that's affecting the bone, but that's just the buccal extension. So our crestal zone, our balance zone, and our aesthetic zone, these are the shapes that we want. You can see them, and now as we go around in a 360-degree view, we're going to have different areas that are shaped slightly different to account for the tissue and how far that tissue is away from the implant. So this is now placed back on. We're going to be checking for any tissue gaps. We're going to be etching and adding more composite if we need to, and then recontouring and repolishing. We want 0 tissue gaps. We want no collapse. We want no unsupported gingival tissue. What you can do instead of taking this back out, etching, adding composite, repolishing, is you could just do a horizontal mattress suture to bring all that together, tighten it up. And that is totally acceptable, especially if you are accounting for tissue loss and you do a connective tissue graft. But it is just easier, takes less time, and gives better contours if you just preserve everything and create a complete seal from the beginning. Okay, so now we're going to go over to the hands-on model demonstration. I'm going to show you how to do this on a model with a new implant. Welcome to the hands-on portion of this training. What we're going to be doing is we're going to be placing an immediate implant in site number 3, and then building our custom socket sealing abutment intraorally on that implant, taking it out of the mouth, filling the gaps, building the intaglio to follow that EBC concept, and then placing it back, making sure that we have a tight gingival seal. Okay, so to get started, we're going to be using the Norris kit and just place our osteotomy, going through our normal drill sequence that everyone is familiar with. We are going to be placing this one in the inner furcal bone. We won't be doing this one as a palatally based implant like the pictures during the presentation showed. So marking drill in the furcation. And since this is a model, obviously it's never going to be perfect like the root in the mouth. All right. Sequential osteotomies here, making sure that we're staying right in the middle, and our exit is going to be in the very middle of the tooth. If only it was this easy in the mouth every time. All right, let's place our implant. Now with the Norris Unicon Tuff, make sure that you're using the Unicon connection for our implant placement. Placing our implant here. Making sure that we stay in the very middle of the perfectly preserved extraction socket. All right, so we torqued out. I'm probably gonna have to make this go a little bit deeper. So now we're gonna measure from the deepest portion of our gingival margin here, making sure that we're at least 4 to 6 millimeters deep from that position, which we are. And then from the center of the implant, at least 4 millimeters from that buccal margin, which we are. So that's going to be our implant placement depth and our distance lingually in the middle of the interfocal bone. So at this point, you could have pre-done this, but if you have different heights of your tie base, if you're going to be doing it on a definitive OEM tie base, or if you're going to be doing it on a temp cylinder or a temp chimney with different gingival heights, you would want to wait to make sure that you don't have any interferences and that you can select the right height of your tie base or temp cylinder. So we have our Norris Unicon lab analog. We're going to place our chimney on this here. So this is all done on the back table. And then we're going to take our Vaseline and our micro brush and just make sure that we are placing our Vaseline below the collar, below the platform, staying away from the platform. And this to prevent any composite from spilling over, making it a more difficult cleanup and polish. So once that Vaseline is on there, we're going to take our heavy flow composite and we're just going to build up about 1 millimeter tall, which is one of these steps. That's why we put the Vaseline on. If you know how much you have to build up based on where this is in the mouth, you can always build up more of this composite up the cylinder so you don't have bare metal that might get blood on it. That will make a more difficult clean. All right. Like hear this. We're going to take this off the lab abutment, lab analog, and then place it on our implant in the mouth, making sure it's fully seated. And then if we have good torque, I would tighten this to 10 or 15 Newton centimeters. For this, I'm just going to hand tighten it. And then we would take a PA to make sure that this is fully seated. And we know that we don't have any bone that is surrounding the temporary cylinder that we need to remove so we can make sure that we get fully seated. Okay, so now that this is in, we've taken our x-ray, we've confirmed that it's fully seated. We're going to take our heavy flow, high viscosity composite, and we're just going to start to build out our arms. I like to make these first ones the closest ones to the gingiva because I can always use these to branch if I need to. And I'm making sure I'm going at least 1 millimeter below the gingival margin. That way we have adequate tissue support all the way around. And of course, with an assistant, you can get really quick at this, where they are basically curing this as you place it one at a time, decreasing the amount of time. So I'm going to go across here. Because this is a heavy viscosity, heavy flow, I can add a couple here before it starts to sag. And if you can see, this is just about the level where I had added composite up the cylinder. So it's going to make filling in easier. So this next one would have been a pretty large gap. I'm going to cure these other ones first, so I don't have to worry about anything sagging. And if I need to, I can bridge to these existing tentacle arms. So what I see a lot of people do when they first start is they just bring this and just go over to the edge like that. And then we don't get enough of that tissue support. So make sure you're going at least 1 millimeter, maybe 1.5 millimeters below the gum, below the gingival margin. So it's easier to start on the gingival margin and then bridge that towards your temp cylinder. So just checking here, we have most of our octopus arms done except for on the buckle, and we just need to make sure that we're at least a millimeter, maybe a millimeter and a half with our octopus arms all the way around to give us enough adequate gingival support. With this model, our bone is actually like 6 millimeters below our gingival margin. That's not always the case in the mouth, as we know. But if I had something where it's this much, we lost all that buccal plate at this much gingival tissue, we would be filling that in with bone graft, maybe bringing this to like 2 millimeters, placing our implant a little bit deeper so we don't get any of this buccal contour shrinkage into that space. Even consider doing like a tunnel membrane here with the bone graft to prevent that gingival intrusion into our bone graft and causing that defect here. But in this case, we're just going to build it as if there was more bone, since we're not going to be placing a bone graft and letting it heal. So I'm going to start at the gingival margin here. Make sure I'm at least a millimeter, 2 millimeters deep, and bridging that towards our cylinder, going back and forth a couple times if I need to, and then going to the next gingival arm. I'm putting a little dollop, a little dab of composite there. That way it just helps create that bridge back to the cylinder. And just kind of letting that sink in between those two dollops, those two dabs of composite. It's important not to rush this because then cleanup gets more difficult. You're spending more time on the back table or in the lab correcting any of these defects. So if you can just keep these arms at a millimeter, 2 millimeters below the margin, pretty evenly spaced without a huge amount of sag between the two, it's just going to make your next step easier. All right, so now this is when I go around the buckle, and in between each, I'm going a little bit deeper just to make sure that I have that 1 to 2 millimeters of tissue support. And just trying to stay level with the gingiva. And if you make a mistake, it's okay. It can be a happy tree. Now we have our buccal tissue support. I'm just going to fill in each one of these individually. I'm not just filling the top layer and just letting it bridge across naturally. I am putting the tip of my composite a little bit deeper and filling in that triangle, filling in that pizza slice. I'm going to do here for the sake of time. Just do a quadrant. And that way, even if we have a little bit of slumping on the intaglio, we don't have to fill in a bunch of gaps, or as this is on a live patient, you just have a little bit of bleeding that's getting into that potentially uncured or slightly uncured part of that composite, which is just going to make adding composite out of the mouth a little bit more difficult because you're just going to have a harder time cleaning up any blood from that composite. So because I was going quicker and I cured all this at once, you can see it kind of pulled away from this margin here. So that's why I, again, recommend just doing one of these pizza slices, one of these triangles at a time. So now that I have the majority of the occlusal filled in, this would be a good time for me to, before I kind of overfill and bulk everything up so it can be polished down later, I do have some flash here. If you are in the mouth, you can take your Explorer and see if you can just chip some of that off so we're perfectly around, even though we know we're about to add some more flash on there. But that way we can take our pencil and just mark that edge. Sometimes that edge will then be covered with composite, but as we're polishing it on the back table, as we see that pencil, we will know that we don't want to over polish that area. And also when you're on the back table, you might think, man, crown is looking like too much like a kidney bean, or it's looking really abnormally shaped. But as you draw this with a pencil, you can kind of see, okay, this is my shape. Maybe I wasn't expecting my crown to look like that. I wasn't expecting the crown at that level to look like that. But if you do it consciously with pencil, when you go back and polish it, you're not going to polish it back too much or contour it back too much into the shape that you think it should be. We know that this is the shape that it is, so we're going to polish it, contour it to that position. So now that the edges are marked with pencil, I do want to overfill slightly because we don't want gingiva to grow over it necessarily, and we don't want to over polish. So now we can just slightly fill in all of our gaps, have a nice rounded base. And I like to do a little bit of flash. I'm sure everyone has their own little unique things that they like to do. But I know I'm going to be taking this and polishing it, so that little bit of flash is going to confirm to me where the height of my gingiva is. But I have it marked with pencil, so I know I'm not going to be confused at what is actually the margin. Cue that. And I noticed that this area here still has a little bit of a divot in it, so I'm just going to go back before I take it off. Remember, the goal is to take this off one time and replace it one time. All right, so now we're going to take it off, and you'll see that no matter how good we are, no matter how careful we are, we're always going to have a ton of voids on our intaglio. One thing that you can do is before you take this off, especially if you're like perfectly in the middle and you have a pretty symmetrical shaped crown emergence profile, you might just want to put a little bit of a little marking to remind yourself which side is buccal. Or if you have a handpiece available, just putting a little divot on the buccal so you know that that is going to be the buccal. You don't have to mess around with anything. Okay, so we're going to take the temporary off that we're building. And usually at this point, there's going to be some heme on the intaglio, which we would then clean off, dry off. A little bit of isopropyl alcohol spray goes wonders. If you have a steamer, take it to your steamer and just like steam it. Try and get as much of that heme out before you start contouring and adding composite to this. So what I like to do, you don't have to go around the whole area, but we know that we have our gingival margin here. We did that when it was at the level, so that's going to be our gingival margin, our superior or our occlusal extent. But we want to make sure that we don't especially once we start adding composite, we don't want to over contour this 1 to 2 millimeters of tissue. So you can always just say, okay, well, I know this is my occlusal extent, so I'm just going to stay at least a 1 millimeter straight here for tissue support. Or you can go with your pencil and you can go to a couple places or trace it as much as you want all the way around to make sure that you don't over polish that. And it's just pencil lead. Like, we're not going for high aesthetics. If there's a little bit of pencil lead that's showing through, I don't know of any studies that's going to be like, oh, that pencil lead's going to affect healing, and I don't really care. So I keep it like that. It helps me make sure that this is contoured properly. Okay, so everything would be cleaned. I'm going to then put this back on our lab analog, hand tighten it. Again, this just allows me to have better control. Highly recommend doing something like this, or else you're going to be just working against yourself. Okay, so now this is cleaned, it's steam cleaned, sprayed it with isopropyl alcohol. You're on your back table or in your little mini lab, you're going to be working on this. And your assistants at this point, or you before you go do that, you're going to place your scan body of choice on the implant. If you're doing digital, make sure it's fully seated. You're going to tighten it, whatever the scan body dictates. And then you're going to leave it like this, let your patients or let your dental assistants do your intraoral scan. So now you have the implant location. If you have to make a 3D printed one, if this breaks, if you have tissue loss, you could just scan it when this is still in the mouth, even if you have a bunch of shrinkage, and then basically redesign it. You can merge those two together in exocad or 3Shape, and then just redesign a 3D printed one with a big hole in it, and then just redo the pickup. But that way you have all the 3D files and you can go into a 3D workflow however you prefer. And then I have them leave this scan body on. I like that it's usually short because we're placing these much deeper. And that prevents heme from filling in or anything from getting inside the implant internal structure. So then in the back table, we need to totally recontour the intaglio. So you can see that even making sure that we had the depth, still get slumpage, we still get all these weird shapes, and we still have all this pore shape. This is not the EBC shapes that we want, so we have to go back and infill all of that. So I want to still keep most of this 1mm that we placed before. I want to keep that as is. Now you can imagine if you didn't do this 1mm of composite beforehand, and you have some composite on there, you're gonna have some blood in there, you're gonna have like tiny little gaps between your composite and the platform, which you try and take this little tip and you try and get it on there, rub it with your finger, rub it with a micro brush, and then you polish it, and then it still has a ton of gaps. So by placing that composite ring on first and going up the chimney, if you know your tissue depth, is really gonna save you a lot of time and frustration later. And again, just like everything, if you do this in too much composite at once, you're just gonna take more time taking it all away and filling in air bubbles that you didn't realize that you had once you start polishing it back. So I just go right from the cylinder where we have like the least amount of material and just basically do concentric rings, trying to fill in all these big tissue gaps. So this is about as much composite as I need. Even though it kind of looks like a T, it looks like it's like sitting on a table. I'm gonna contour most of this. I put a little bit more right here just so I can blend that area a little bit better, so we don't have such a distinct junction between our bound and crestal zones here. Okay, so now we're gonna take this to a different location so we can do all the polishing and shaping of the intaglio surface. So here we are in the back table now. We're going to use mostly just the burr block that I use for mine, but I might switch to some of these other burrs. A lot of times I'll be in my lab, like with the straight lap handpiece, to do some of the final polishing to get a really high shine. We're not necessarily going to do that today. We're going to pretend that we're chairside, and we're just going to do this as a quick gross reduction. So the first thing I'm going to do is I'm going to take my diamond burr, and I'm just going to start to come up here and do some occlusal gross reduction, make this all nice and flat. We don't want food to be accumulating here. We don't want debris to be accumulating, plaque and calculus to be building up, causing spillage. So just making sure that as I do this, my pencil line that I marked way back when, I'm not reducing the occlusion more than that. Just smoothing everything up, making it a nice firm surface. Okay, and then I'm going to switch to the intaglio here. Same with my gross reduction burr. This is more of a trial by error thing. You get better at it. You kind of start to know what to contour once you start being really self-critical of your work, and then seeing how things heal, which of course just takes time. But you just want to make sure that you keep that straight zone, and then this here is all concave, and then you keep your aesthetic zone, your buckle support, straight or slightly convex. I like to keep these contours as gentle as possible, just like MUA design. Like the more gentle that contour is, the more the tissue likes it. Okay, so that's most of my gross reduction. I'm not going to do too much more with the black striped burr. I'm going to go more towards my finer diamond. There's like a weird, you can see with the white dust here, there's this like weird transition zone. Great place for bacteria to live. So I'm just going to very gently smooth that transition line. Okay, so that is most of the reduction on the intaglio. I'm going to then just switch to my coarse burr again. I'm just going to cut this cylinder off. I almost always cut the cylinder off in the lab with a mandrel, but let's see if we can just do it here. And we will be filling this in with composite, so it doesn't have to be perfectly smooth, and that composite can run over to the sides a little bit once it's in place and we have confirmed full seating. So that doesn't have to be spending a lot of time reducing that chimney there. All right, let's go to our white stone and get some polishing going. So at this point now with my white stone, again, I don't want to, even though I overfill this, I don't want to be reducing a lot. I'm okay to be more occlusal than the gingival margin. Like, that's not going to hurt, just like a tooth is more occlusal than the gingival margin. I just don't want to over-reduce deeper. The nice thing with the white stone is once you start getting to your pencil line, it starts to make your burr get a little darker. Some of that pencil lead transfers, and then just by polishing somewhere else, it cleans it off. So if your burr gets dark, I'll go purposely on like one of these pencil margins like right here, and you'll see that like the tip there is now a little bit blacker. So now I know that I'm right at that pencil margin. From the side, if you're looking straight down the edge, I have that little bit of flash that I purposely built in. It's going to very, very gently just take that flash off. So it might be hard to see, but I'm starting to see that when I move this in the light, I'm starting to see some shining, which shows me that I'm getting near to the end of polishing. Just like way back in dental school, the shinier the better. Same thing with this. Alright, so then I'm going to go to my last one here, which is the greenie, and get the last little polish. So now the only time I'm actually really going on to the surface that's supporting it is with my final polish. So if it's going to be the green, again, I'm not like really digging into it. I'm just going very lightly just to take any little bit of flash off and just to give that a little bit of polish so we have some inconsistencies. If we had a little blood that got in there and caused like a little divot, at least it can be as polished as possible to prevent more bacteria growing in there. And the most important part is after you've gotten this all done is spraying it with alcohol, 95% or higher isopropyl alcohol, and then putting it in the ultrasonic bath in a bag with alcohol for 5 minutes. And that's going to take away any of this powder that's still on there, and then decontaminate it. That's looking pretty great. So I'm going to go put this in the ultrasonic with some alcohol. I have a steam cleaner, so I would steam clean this. So we'll do that, and then we'll go back to the model and see how everything fits and how everything looks. So now we've taken our custom socket sealing abutment out of the ultrasonic, out of our alcohol bath. We're going to go back into the patient's mouth. We can take off our protection cylinder, or in this case, our scan body that's acting as a protection cylinder, prevent blood clots from forming, and we're going to have our socket here. Now, again, I prefer to only put this back on once. So at this point, what I would probably do is I would take my bone graft material, pack my bone graft, not overfilling. Remember, I just want to support any buccal tissue, graft the gap in the extraction sockets if I need to. But anywhere there's a blood clot is going to form bone, especially if we have a custom socket sealing abutment to preserve that blood clot, prevent it from having gingival ingrowth, prevent it from having saliva that washes it away. So if we have a good custom socket sealing abutment, any bone graft that's in the socket will stay, but we're going to place bone graft to protect any buccal deficiency that might have shrinkage or any unsupported gingival tissue that isn't going to be supported by our custom socket sealing abutment. So bone graft, whatever graft that you're going to place is going to go in. And then I like to do PRF for almost every single surgery. So I'm going to have like a poncho, PRF slug that I'm going to fold in half, put a little hole in, and then put it underneath this as like a poncho. And then I'm going to place it back on the implant, going in, making sure we mark the buccal, and the buccal goes towards the buccal, making sure it fully seats inside of that internal hex, and then slowly hand torquing it in place. At this point, if you feel like there's like a bone chip in there, if you feel like you're not fully seated, it's better just to readjust than to take an x-ray and see if you can feel that it's not fully seating. If you know that you're much higher than you originally were, just take it off and make sure there's clear of any bone chips or anything that's preventing it. Maybe you pack too much bone and the bone is now compressing against the edges and the margins, and you're not able to compress the bone more to get that to fully seat. So take some of your bone graft out, make sure it's fully clear, and then seat this all the way. Once you're pretty confident that you're fully seated, torque it to 15, 20 Newton centimeters, and then take your PA x-ray, confirm that you're fully seated, make sure that it looks exactly the same as your initial PA x-ray of the unmodified, or when you just had that 1 millimeter collar of composite in place, to ensure that you have a full seating. Because if you're resting on bone, if you're slightly off, you maybe put too much bone graft in, and now you're compressing that bone graft and you're raised up slightly, even half a millimeter, quarter of a millimeter, what's going to happen is the body doesn't like that compression. It's going to resorb that bone, and now you have a loose abutment that's going to have micro movements, and that micro movements is going to create openings on the side of the tissue. It's going to cause tissue inflammation. It's going to cause potential infection, irritation, bone loss, gingival loss. You're going to be dealing with a mess. Also important to counsel these patients, hey, if that feels loose at all, like, let me know right away. It's better to address it and just tighten it down by hand than to, have that patient think there's something wrong and go 3 or 4 days or a week with a slightly mobile custom socket sealing abutment. That's going to totally change how everything heals. So then we're going to just check with our perio probe, and we're basically going to see if we have any really big openings in our tissue. If I was being really, really self-critical, like this tissue here could be a little bit better adapted. It's not major. It's nothing that would be like so unacceptable that we would lose all of our contouring. So in this case, I might just take a little bit of composite and add it and light cure it and then just leave it, because it's such a small area. If it's a bigger area, I would recommend taking it out and then etching it with 37% phosphoric acid, and then adding the composite, putting it back, adding the composite, because that highly polished composite just doesn't like to have a small or a big area that might have any compression that's going to cause that to chip off. But a small little area like this, I would just put a little bit of composite in, light cure it, and then call it good. Those usually don't have any major issues, but something like this I wouldn't even bother with, or I would just put a horizontal mattress and just cinch it down, just give it a little tightness. Definitely do that if I was adding any buccal tissue. But this is pretty much good all the way around. I have tight sealed sockets all the way around. And that's it. Cone beam at the end to make sure that you're not in the sinus, you're not in a nerve, you're exactly where your implant's supposed to be. Send the patient home, do your standard follow-up, and go from there. Okay, so documentation is key. Be sure to take photos, okay? This is your take-home message. Take photos, document your steps. Not every single case is gonna be Instagram worthy, and that's totally okay. This is a learning process. You're gonna get better, and the only way that you can self-critique and learn from it is by documenting. So take as many photos as you can. Make your preoperative or perioperative photography part of your daily patient flow. So teach your assistants. My assistants remind me all the time, hey, don't forget to take photos. Hey, don't forget to take photos. We've got to take a photo of that. We need to take an x-ray. If they know how important it is and you teach them how important it is, they will make sure that when you're in the flow, when you're in the zone, when you're worried about time, that you still remember to take those photos. The most important thing with assistants, if you're teaching them to take photos, is to teach them how to evaluate a good versus bad photo. So, oh yeah, this photo has the lip in the way, or this photo, we should have suctioned the blood away first so we actually see what we're looking for. Like, this is what we're looking for. This is what I want you to be looking for in the photo to know if it's a good photo. Otherwise, you're going to rely on your assistants to take photos, and you're going to be like, man, I can't use any of these photos. I can't self-critique with any of these photos because I didn't teach them what a good photo was. Like implants, photography is a whole separate set of skills, and it takes time to learn. You don't need the best camera in the world when you first start documenting these cases or any of your cases. Just your iPhone is fine, and then as you get better, as you want to get documenting more, and you become more self-critical, then you can start taking the courses or advancing your skills, getting better cameras, getting better gear, etc. Thank you so much for attending and watching this webinar about placing immediate implants and building custom socket sealing abutments. I hope you learned something from this. I hope you go back to your practice and you start experimenting, placing these, building up your own custom socket sealing abutments, and preserving that gingival tissue of your patients for long-lasting, beautiful crowns.